Good afternoon. My name is Dr. Joan Reed, and I'm Dean for Diversity and Community Partnership at Harvard Medical School. And thank you for joining us for today's webinar on Pharmaco-Equity. This webinar is part of the Harvard Medical School Office for Diversity, Inclusion, and Community Partnership, DICP, Equity and Social Justice Initiative, which was established to address issues related to health disparities, social determinants of health, leadership, health system, health policy, and other areas affecting vulnerable populations. ESJ events focus on 4 areas: history and context, culture and environment, health disparities, and leadership and skills development. As he said, the series is sponsored by the Harvard Medical School Office for Diversity, Inclusion, and Community Partnership. The mission of DICP is to advance diversity and inclusion in health, biomedical, behavioral, and STEM fields in ways that build individual and institutional capacity to achieve excellence, foster innovation, and ensure equity in health locally, nationally, and globally. DICP efforts support the career development of junior faculty, trainees, and students, identifies and trains leaders in academic medicine and health policy, and provides programs that address crucial pipeline issues. A few housekeeping notes as we begin our session today. The chat is not available. Your microphones will be muted, but you can use the Q&A to post questions to panelists. The webinar is being recorded and will be posted on the DICP website. And now it's my pleasure to introduce Dr. Alden Landry. Dr. Landry is an emergency medicine physician at Beth Israel Deaconess Medical Center, Associate Professor of Emergency Medicine and Assistant Dean in the Office for Diversity, Inclusion, and Community Partnership at Harvard Medical School. Dr. Landry.
Thank you, Dr. Reed, for the introduction, and thank you to all of our audience for being here. I'm excited to be a part of this discussion and really talk about an issue or a handful of issues that probably go under-discussed in medicine and in health professions in general. And we're going to have this discussion focusing around pharmacoequity and pharmacy deserts. I've invited along some new friends and colleagues to join in this discussion and really help us to lead this fruitful discussion of what we can do to address pharmacoequity issues that we are seeing within our patient populations, and also sort of addressing this from both a local and community level as well as on a policy level. And so I'm going to give some brief introductions of our panelists, and we're going to jump right into the questions that we have prepared for them. As Dr. Reed mentioned, we do have time for Q&A towards the back end of our presentation. So if you have a question or a comment that you would like to bring to our panelists, please do so using the Q&A function that we have available. So as I mentioned, our presenters are absolutely amazing, and I'm going to be very brief in their introductions just for the interest of time. So first we have Dr. Jacinda Abdul Muda Kabir, and forgive me for mispronouncing your last name, Muda Kabir. She is an assistant professor of clinical pharmacy at the University of California, San Diego, in the Skaggs School of Pharmacy and the Division of Black Diaspora and African American Studies. She completed her doctorate of pharmacy at the University of St. Joseph School of Pharmacy in Hartford, Connecticut, and her residency at Howard University Hospital in Washington, D.C. She also completed an infectious disease pharmacodynamics research fellowship and went on to earn a master's in public health at Wayne State University in Detroit, Michigan. You can read more about Jacinda on our website, and I'll be sure to post her bio in the discussion as well. Next, we'll hear from Dr. Utibe Essien, who is an assistant professor of medicine and assistant vice chair of equity, diversity, and inclusion for the Department of Medicine at the David Geffen School of Medicine, University of California, Los Angeles. He received his medical degree from Albert Einstein College and trained in internal medicine at Massachusetts General Hospital and Harvard Medical School. After residency, he remained at MGH and completed a research fellowship, as well as went on to earn a master's in public health from the Harvard T.H. Chan School of Public Health. Again, you could read more about the work that Utibe is doing in the bio that we'll post. And last is Dr. Dima Mazen-Kato, who currently serves as the Hygeia Centennial Chair and Associate Professor at the University of South Carolina School of Pharmacy, where she is currently leading the program of medicine and public health. She holds an appointment as a senior fellow with the USC Leonard D. Schaefer Center for Health Policy and Economics. Prior to joining USC, Dr. Cato was an associate professor in the Department of Pharmacy Systems, Outcomes, and Policy at the University of Illinois at Chicago College of Pharmacy. She also serves as a National Academy of Medicine Pharmacy Fellow. Dr. Cato received her PharmD degree from the University of Illinois at Chicago, an MPH from Johns Hopkins School of Public Health, and her PhD in Public Health from the University of Illinois School of Public Health. And again, you can read more about her bio as we post it along. So we're going to turn to our panelists now on this great presentation, and I'm going to go to you first, Jacinda, because I'm hoping to get a little bit of a better understanding of the terms that we're going to be talking about. And I want to also hear from you as someone who may have some experience really working directly with patients as they try and access medications. So we often use this term frontline when we describe working with patients directors. Can you tell us what has been the experience of on the front line of pharmacy care?
Absolutely. Thank you so much, Alden. Thank you for having me. Thank you for the question. And then for the audience, and I guess for the panelists, so I do go by Jam, like peanut butter and jam. So, because the last name, right, it's intense. So Jam is good if we want to use that moving forward too. But I think that it's really exciting when I think about the landscape of just frontline. I guess is being on the front line super exciting? I don't know. But I think it's exciting when we think about what it's looked like for pharmacists since the pandemic and amid the pandemic and while we're still in the midst of the pandemic. And I do have a slide that just allows for us to keep everything straight. So the first slide that I have, it says pharmacists on the front line. But I think the best way for me to kind of go about this was to separate it into just 3 different areas. So I like to come at it from the education standpoint. So I know that, the media portrays pharmacists and pharmacy in a specific light, and it doesn't do us a lot of favors a lot of the time. But contrary to what we all see on Nurse Jackie, when it comes to pharmacy, pharmacists have really been so integral here. So first and foremost, I like to talk about just from the education standpoint. So how often is it that patients and individuals within communities rely a lot on their neighborhood pharmacists in terms of the decisions that they make pertaining to healthcare? So that education that they can receive or that hardy decision to be vaccinated can oftentimes come from that prompting of the pharmacist. So of course, pharmacists have been really important there, but I also want to talk about just from like a national kind of standpoint of how it is that we're tackling the pandemic and the guidelines that are required to go ahead and combat the pandemic. And pharmacists were included on those NIH guidelines, those NIH task forces in terms of trying to figure out how it is that we use the COVID-19 therapeutics. But then not only that, when we think about antimicrobial stewardship, because that was something that we were really faced with, during the pandemic, that we're faced with now as we continue to think about just the landscape of antimicrobial resistance. This is just, a brief plug. I got to make sure I show my ID badge right now. But let's think about that as some of us are clinicians and we're moving forward. But when we think about it from a stewardship perspective, pharmacists have really had to have that lock and key on how it is that we navigate with those therapeutics for superimposed infections. So it's been a lot of education there. But what I really am excited about and what I love to see from pharmacists lately has been the advocacy. So it's been advocacy from inside the community pharmacies. It's been advocacy in the pharmacies that are pharmacy-like operations that have been set up right into communities. It's been a lot of advocacy there to ensuring that drugs are delivered equitably. But what I really love to see was just the leadership from our pharmacy organizations to really make sure that we did a lot more in terms of the equitable distribution. So for Insight, the National Pharmaceutical Association, in collaboration with the Society of Infectious Diseases Pharmacists, they issued a statement actually to the CDC and of course to alert the different areas of the Biden-Harris administration to talk about just the lack of distribution of the vaccines initially into minoritized communities, because we saw that disproportion very early on throughout the pandemic, but it also advocated against the policies that were in place, which kind of put individuals of racially and ethnically minoritized groups at a disadvantage. And then also when it came time for those COVID-19 therapeutics, so those oral antivirals, Paxlovid, and so on, we saw once again that disproportion of those individuals that received these therapeutics well, the Society of Infectious Diseases and National Pharmaceutical Association and the American College of Clinical Pharmacy also saw this. And once again, pharmacists of these orgs penned statements really advocating for that equitable placement, but then also advocating for pharmacists and pharmacists receiving reimbursement, pharmacists receiving payment for issuing these services, because that's how we make sure that we have sustainability. So I really love to see that. And it really kind of molded and reshaped what being on the front line meant for me, but then more importantly, the action that we've seen. So 60% of the COVID-19 vaccination doses, actually more than 60% at this point, have been delivered by pharmacists or other pharmacy staff. So that's a really major role that pharmacists have occupied during the pandemic. But then also when we think about action from the perspective of, those vaccines that are being provided in the pharmacies, we also have to think about, well, these pharmacists are also going into these communities for these individuals that have that lack of access to transportation, the lack of insurance, or honestly, we know that the vaccines, we didn't have to pay for them, but a lot of patients don't know that. So those pharmacists went into those communities to make sure that individuals were able to receive vaccines and then also the therapeutics. So it's been a lot of different areas where pharmacists have really shown the utility of having us in place within the front lines.
And it definitely sounds like, there was not just motivation, but true engagement and outreach that pharmacists were involved in and really reaching some of those patient populations that have been historically excluded or ignored by our healthcare system, especially when it comes to the pandemic. One of the things that I wanted to really discuss was an issue that we had here in Boston. Recently, a pharmacy chain closed down 3 pharmacies in predominantly Black and Latinx neighborhoods. This created what is called a pharmacy desert in those communities. How common is this as far as the concept of pharmacy deserts? And what is the impact that it's having on those historically marginalized communities?
Yeah, thank you so much for that question. And I know that Dr. Cato, this is her sweet spot. So I am not going to step on her toes there. Please correct me if I'm wrong, but I am going to provide just my perspective on pharmacy deserts and so on. And coming from, so I was born and raised in Detroit, Michigan. So I lived in a pharmacy desert. So this was actually something that I came to learn when I was in my master's of public health program, but it's really been something that I have just it's really opened my eyes just amid the pandemic and really just seeing the impact that these pharmacy deserts do have. But nevertheless, I think it's important that we think about the fact that 80% of counties across the United States have inadequate access to some type of healthcare infrastructure. And in that healthcare infrastructure, it can be inadequate access to pharmacies. So that's 80 counties. So that's 80% of counties. So when we think about that, history would kind of put us into that perspective where we would think about, well, who are these people that are likely going to be at this disadvantage? Well, it's going to be individuals that live in lower socioeconomic areas, because those are a lot of times areas that go forgotten, areas that go unchecked. So it may be, or areas where individuals may not want to work in the pharmacy setting there. So it's easy to go ahead and shut those pharmacies down. So a lot of times the deserts do exist in those places. Over 40% of counties that are pharmacy deserts are in racially and ethnically minoritized communities. And that means that it takes greater than 15 minutes for individuals to reach or receive pharmacy services. But then I think that, so kind of getting off that, yes, it does exist to where these chains will shut down pharmacies or where folks will have less access. I think that we also have to think about the fact that minoritized individuals are less likely to have a primary care provider. So that being, physician, a mid-level practitioner, so on and so forth. 30% of minoritized individuals. So when we think about drug equity, when we think about individuals of Black and brown groups, and yes, they may receive, medications to a lesser degree, then we have to think about, well, what is the practical reason for this? Like more contemporarily, well, discrimination, stigmatization. Now these individuals don't want to go and seek healthcare. So when they don't go and seek care, now they don't get medications. So then not only do we have these pharmacies shutting down in these areas, but we have to think about, well, they might be shutting down because no one's coming in there to receive therapeutics. What is the reason for them not having received these therapeutics? So then we end up in this kind of circle of, or chain of events anyway. So I think that's also kind of another perspective that we don't really necessarily think about when we look at the disproportion or weight or why pharmacies may be closing in racially and ethnically minoritized areas, but it's definitely a problem. And it scares me when I think about the landscape of what this will look like as we move forward throughout the pandemic, and just when we think about jobs, when we think about just the inequities that were exploited and that have expanded amid the pandemic. I'm very nervous about what the landscape of pharmacy deserts is going to continue to look like.
And so going along, it sounds as if you're sort of painting a bleak picture of what could potentially happen, but maybe let's spin this and think about it from a perspective of an intervention. And so what are some interventions that can be put in place to help address this lack of access to pharmacies, specifically for those marginalized communities that we're discussing?
Right, absolutely. Thank you so much for that question. And I do have the last slide that I have there. I kind of depict how it is that I think about it anyway. This is just my opinion and my standpoint. But I think there are many things that can be done, to address this. But I think that we have to end up in that place where we are honest about the fact that we are in a place where Pharmaco-Equity is not a reality. We are in a place where there are pharmacy deserts. We are in a place where Black and brown individuals and other marginalized identities are receiving less care, that this is an issue. I think that we all have to collectively acknowledge that. And I think that there has to be a strengthening of collaboration amongst the different healthcare disciplines. So, we have pharmacists that have amazing things that we can uniquely provide. Physicians have amazing things they can uniquely provide. Nurses, public health individuals, we need to combine our efforts to ensure that we keep that same motivation at the forefront of our minds. We have to really make equity a priority, in my opinion. And I also think that we have to continue to position the community as front runners in what it is that we're doing here, as really the leaders in this work. I do a lot of work in terms of COVID-19 and just vaccine equity in general within racially and ethnically minoritized communities. And one thing that has really propelled us forward is the community's involvement. So we originally joined forces with 2 faith organizations. And amongst those faith organizations, there were about 40 or so leaders that we were able to get into contact with. And through the collaboration with those leaders, we were able to drastically increase the vaccination rates within the Black and Hispanic Latino individuals that we were serving there in the community. So we have to really, really, really engage our community leaders or organizational leaders, because when we think about just inequities that exist, who is it that would know better than the individuals that are actually in the community, than the individuals that the community can trust? But I think also we have to think about how it is that we engage the community, how it is that we expand, these services and the things that we're working to do. Well, we have to also be known as trustworthy individuals within the community. We can't do many things with this current landscape of just miscommunication, this current landscape of mistrust and distrust of different healthcare individuals and the healthcare kind of like as an institution. So we have to really work with the community leaders, and it takes work. And I will say on my behalf, it has taken a lot of unpaid work, but it's been just very important, because I knew the disparity that I was seeing, and I knew the best way for me to tackle it was to show that not only was I willing to listen to what it is that individuals of the community wanted to say, but to let them know that what it is that they felt was validated. And I think that's important. And then also, as we expand, we want to think about integrative, collaborative health equity research hubs. And I think that's something as we, as individuals of the healthcare, of different healthcare settings, can really do within these groups. We can really create these collaboratives, really lead these initiatives to further engage the community. And then finally, I think it's important that we create different low barrier types of opportunities for us to deliver healthcare services. So as I said, we originally started this effort with solely vaccination clinics, but now when we do this effort, we have in-person town halls where we talk about the COVID-19 vaccines, talk about the COVID-19 therapeutics, and then we have a vaccination clinic. So it's important, to make sure that we're increasing health literacy, but then also providing health access at the same time. So then hopefully that being a sustainable approach to making sure that we can create a more equitable infrastructure, but then also we involve healthcare students, for public health students within this initiative, because for true sustainability and for true commitment to the community, I do think it's very integral that we start training the next group of healthcare professionals to provide healthcare with this mindset at the forefront. And then lastly, I want to say that when we design research, when we publish this research, that we are doing essentially, with the strict motivation and that buy-in from individuals of the community, we have to give them authorship. We have to make sure that we provide them funding to continue to do this work. We have to show them that we're just as invested as they are. So I think that, it's a lot of different elements to increasing health equity, but more importantly, we have to think about how do we let the community really lead us and how best to serve them.
So that last statement was a whole message right there. And I really do appreciate how, candid and honest you were with the discussion. I mean, we often overlook our communities. We go and research the communities, but don't invest in the communities that we're researching. And I think it was really poignant the way that you captured that discussion. So thank you for your presentation and thank you for joining us. Utibe, I want to turn to you next. First, I have to apologize because as you can see, I'm not wearing a bow tie. And Utibe has sort of been, the lead as well as another colleague of mine in encouraging the wearing of bow ties for us Black men in medicine. So I apologize for my appearance today, Utibe. But you actually introduced me to the term pharmaco-equity. And can you tell me what that term means and how did we get to this point when we're discussing an issue around pharmaco-equity?
Yeah, for sure. And so, yes, definitely a little disappointed, Alden, that you didn't pull through this year, but I think hopefully in our next session, you'll be able to come through with the bow tie. But I definitely am, first of all, honored to be part of this panel, especially my two colleagues who are leaders in the space, like you said, on the front line, but also in the policy space, coining the term pharmacy desert, like we'll hear from Dr. Cato. So it's really awesome to share this virtual space with you all. My work we'll talk a little bit about really is thinking about ensuring equal access to cardiovascular therapies for racial and ethnic minorities. And as I started kind of down this track in residency and fellowship into my early careers on faculty, really seeing that the themes that were coming up around disparities in treatment were so not unique to the disease condition that I study, which is atrial fibrillation, but we see it play out in infectious diseases like Jan was talking about, like cellulitis. We see it in cancer treatment, in you name it. We see these racial disparities exist, and we've seen them exist for so long. I think when as I was starting this work in particular, obviously the pandemic came up, like we've talked about already, and we saw disparities in testing for COVID and vaccination for COVID and hospitalizations and death. And then when these new exciting therapies came out to treat the infection, we saw the same exact disparities take place. So Black people, Hispanics, certain Asian groups, Native Americans were not only getting infected and dying more from COVID, or also then less likely to be treated. And that just doesn't make sense, as I'm sure any of you can imagine. And so again, thinking about the whys is really why me and my colleagues came up with this term pharmaco-equity, so that we could expand this goal of ensuring that every patient has equal access to life-saving therapies, regardless of race, ethnicity, socioeconomic status. And really make sure, again, that we're coming up with strategies that are not just talking about patients' lack of adherence or non-compliance, but we're thinking about some of the broader levels, what's going on at the provider or the clinician level, at the health system level, the physical infrastructure, like we've talked about, and of course, the policy level, which I think is a big lever that we as clinicians don't often think about, but is so critical to this specific topic.
And so, you mentioned in your introductory statement about your research, and your research centers around access to medications for a specific population, especially looking at your work at the VA when it comes to access to medications for AFib cardiac or atrial fibrillation. Can you share maybe a little bit of the details that you found in some of the studies that you've been doing?
Absolutely. And so I didn't have any slides prepared today, but lots of references that I imagine that we can put in the notes or in the chat for folks who are interested. So I really started this work out of residency, a patient that I was taking care of as a primary care resident back in Boston. I was practicing in Chelsea back then at one of our community health centers. And saw this gentleman who had a new diagnosis of atrial fibrillation, which is not always being referred to or talked about on the news, on TV, et cetera, but is really an increasingly common condition. About 6 million people have atrial fibrillation or AFib here in the US. And so this gentleman was put on one of the older treatments to manage and prevent strokes with atrial fibrillation called warfarin, as opposed to a newer therapy that just in the last decade or so became more available. And this is a Spanish-speaking gentleman from El Salvador, and who really struggled with this older medication. And some of the challenges with this medication is you have to come in and get blood draws. You have to kind of change the dosing and treatment level of that medication depending on your diet, on other medications that you take. If you drink alcohol, for example, which is one of the conditions that this patient struggled with. So we really had a tough time managing this individual with this condition. And it's something that, again, I would see time and time again, not just with my patient. And so, had the opportunity to have some data to study this question during fellowship and saw really wide racial disparities in the use of these newer blood thinning, stroke preventing medications for treating atrial fibrillation. And this is back in 2018. We published our first study showing these racial disparities. And then I had the opportunity to join the faculty at the University of Pittsburgh, where we decided to look nationally in the VA, which is a uniform health system. They have a low cost formulary. So back during residency, patients were paying anywhere from $200 to $300 a month for these medications. And the VA patients only pay about $11 at max for these medications. And so we're, hypothesizing that surely we're not going to see the same racial disparities in the VA. And again, a few years later, we finally published the data in 2020 that showed sadly that there were racial disparities in atrial fibrillation treatment, even in the VA. And so really, unfortunately, we're seeing again that across different health systems. So we've looked outside the VA nationally, within the VA, we use Medicare data, all various data sets that we're seeing these same disparities persist. And really our question now is why? How do we get to understand what's going on in our patient provider conversations? How do we address this huge elephant in the room, which remains cost, and advocate, like Jam was mentioning, for our patients? And again, that's kind of where the focus of our work is moving forward, moving beyond the description of these disparities to really start to intervene, like you mentioned earlier, Alden.
I was struck by a couple of points in what you just stated. One is how a patient's story or a patient interaction has led to a question that led to an investigation that has led to really a body of work that was needed in this discussion. And I think it's important that we realize that when we hear those patient concerns, when we hear those patient complaints, it's important for us to take those things seriously, because that could have, reverberations, not just for that patient, but for others in that community, for others across the country. So I think it's really important that we stress the voice of our patients in these situations. And so thank you for sharing that. And I also think it's really interesting to hear that, we talk about, cost and, all these other things that could potentially be barriers. And when you're talking about a situation where, you're controlling for all of that and you're in a system where really it comes down to what the physician puts down on that prescription pad or sends electronically in this day and age that we're in, and sends to the pharmacy, that there could potentially be some bias or some issues that are happening at that physician level that are preventing our patients from getting the best medications available for them.
Yeah.
So, I want to just finish up on a point. What are some take-home messages for the physicians that are listening, for the physicians in training, for the other clinicians that are listeners? What are some take-home points for us as we're caring for patients who may be vulnerable to systems or to our own individual bias that leads to these issues related to pharmacoequity?
Yeah, so the take home I always use are ABCs just because they're easy to capture. And I think for this case, the ABCs are thinking about access, bias, and cost. Um, and so the access issue we talked about already with Jacinda, thinking about pharmacy deserts, just literally the geographical access to the therapies that we prescribe for our patients. But for us on a day-to-day basis as clinicians, I think we have to get creative about what that access means. So Jacinda mentioned that preponderance of individuals who don't have a primary care doctor are from racial and ethnic minority groups. But if we go beyond that, we think about access to specialists. We really see similar disparities in that vein as well. Thinking about some of the medications that we prescribe, newer, advanced, evidence-based therapies, those often end up being prescribed at the pharmacy by the clinical specialists as opposed to primary care docs, generalists, EM docs like yourself, Alden. And so how do we continue to think about and improve access to specialists is something that we as clinicians on a day-to-day basis can do, whether that's opening another slot in our specialty care clinics, especially for some of these larger academic medical centers, opening that weekend slot, that nighttime slot, again, hard to fill because our lives are so busy, but again, getting much more creative about access as we think about our patients' busy, hectic lives. The second point, again, we've talked about it, I think we're going to talk about throughout today, is thinking about bias, that we have to acknowledge the data around bias in care. There was just a study published last week in the Journal of Clinical Oncology that showed that Black and Hispanic individuals at the end of life are less likely to receive opioid treatment compared to white individuals who have cancer. I think we just need to sit with that data point for a little bit. There's so many reasons that people will probably throw around as to why that exists, but those are the numbers. Those are the data. People always say, we know disparities exist. We don't need another study. And then furthermore, say they're so shocked and in awe that these data exist. Why is that going on? Not just in 2023, but for the last couple of decades. And again, across whatever condition that you want to study. And, is it just that we don't trust that patients know how to manage their pain appropriately, and so we don't feel comfortable prescribing them these therapies? And then when it's not a medication that has some kind of complicated bias, et cetera, with it, why do we still see racial disparities in that? And I think knowing these data and being as familiar with them as possible, just as we're familiar with the Krebs cycle and every other pathway that we learned about in our medical and residency training, needs to be a key and parcel of our training and practice. And so lastly, the ABC is cost. So again, I think a lot of us want to ignore the fact that cost is such a big part of care in our health system, but we just can't ignore it anymore. And so not just trying to look for the most affordable medications for our patients, working with our pharmacy colleagues to ensure that our patients have access to the best medication, working with our social work colleagues to help us complete whatever prior authorizations need to take place, even when it takes more time and effort for us, and coming up with systems so that job is easier for us as clinicians. But also getting out there and advocating, whether that's joining our favorite medical society to go up on the Hill to advocate to our Congress people and senators that we're not going to settle for medications being way too expensive for our patients to actually be able to lead healthy lives. And so I think as clinicians, we can address those ABCs and still be able to practice on a day-to-day basis in a way that is clinically satisfying to us as well.
Thank you for adding another ABC acronym to add to the list in medicine. More for us to teach when it comes to our trainees, and hopefully simple enough for them to remember. Dima, I want to turn to you because Utube is sort of ended on this discussion on advocacy, even as much as going to Capitol Hill to have these discussions around Pharmaco-Equity and addressing pharmacy deserts. From a policy perspective, what are organizations, governmental organizations, affinity groups within pharmacy, et cetera, what are they doing to address these issues related to Pharmaco-Equity and pharmacy deserts?
Yeah, that's a good question. I mean, the short answer is they're not doing enough. And I think when they're trying, so I'll give examples of what's been done and why it's failed and what should be done at the minimum to at least improve access to medicines and pharmacies. So if we just go back to use the COVID pandemic, it's been a theme of our lives for the last several years, and I'll just kind of continue on that theme. One of the first things that were done once the vaccine was available is to create this federal retail pharmacy program, right? Which was tasked to distribute vaccines across the country through states contracts and retail pharmacy contracts. And initially, those contracts were mostly with chain pharmacies. And that was a federal program that was funded. And what our research showed prior to that, 10 years ago, our first Pharmacy Desert paper, and you can put up that slide, Lynn, is that, not only were there pharmacy deserts, but the nearest pharmacy in communities of color are oftentimes independent pharmacies, not chains. So if you kind of look at that example of a policy, a program, the federal retail pharmacy program, and how it could potentially contribute to worsening disparities, not just in COVID, but in COVID vaccination rates that were early on blamed almost exclusively on vaccine hesitancy, which, is partially is an issue. But I would say, vaccine access is an issue. And by design, through the retail pharmacy program, pharmacies that were closest to neighborhoods that are predominantly Black or Latinx, were excluded from participating, which means that they're not getting the COVID vaccine, right? It's the pharmacies that are retail chains that are really receiving them. So that kind of just illustrate, as an example of how it plays out even across the board, right? So independents are also excluded from Medicare preferred pharmacy networks, oftentimes. They're also excluded from 340B contracts. And, I don't want to use too many acronyms, but these are federal programs, right, that support access to medications. And these programs often exclude pharmacies that are serving these communities of color, communities that are pharmacy deserts. So if they aren't now, if you can go to the next slide, and this is just to kind of show you a timeline. This is a paper that we first published in Health Affairs almost 10 years ago. It's crazy, but 10 years ago. And this is just updated data on Chicago, which applies to Boston and other LA and cities across the country and even rural areas, is that in this time period, what you see here is a map of Chicago in 2020, right? A pharmacy desert in 2020 versus 2015. And it's gotten worse. It hasn't gotten better. And that's partly because of policies like this, federal policies that exclude pharmacies. When I say exclude, it means that if you have Medicaid, if you have Medicare, even if that pharmacy is in your neighborhood, you really can't use it. And kind of going back to Jam's point, right? Like if you're not, people aren't using their local pharmacy, not because they don't want to, it's because they can't. And if they did, going back to the cost issue, they have to pay more. So what's more inequitable than forcing members of a community not to use their local resources and forcing them to travel more than other neighborhoods, right? I mean, they already have to travel further at baseline, but even, with these kind of policies that are embedded, which I say are kind of a form of structural racism in Medicare, in Medicaid, also in private insurance. But, at the minimum, we got to fix it within Medicare, within our public insurance programs. They by design. So if you're not, our research has also shown, so if you're excluded from a network, which means that, if you have Medicaid or Medicare, and this pharmacy is a pharmacy that's excluded from the Medicaid plan that you're signed up for, it means you really can't use it. And if it's not preferred, which is another kind of function of managed care over the last 10 years, if you use it, you have to pay more. So what we see is that most pharmacies in communities of color are pharmacies that are not preferred. And if they are in network, and many of them are also out of network. So, so they're, basically destined to close, creating more pharmacy deserts, which is what we found when we compared kind of the situation in Chicago in 2020 compared to 2015, right? Didn't get better in these communities, even though we did a lot of advocacy. We even introduced some legislation at the state level. It really became a standstill. What needs to happen is policy. I mean, I think kind of short-term interventions at the patient and community level are critical, right? Like during COVID, okay, these areas are pharmacy deserts. There were some communities and county health departments that did outreach. They sent mobile units to these neighborhoods to ensure they get vaccinated. I think that's great, but that doesn't address access to medications, right? It addresses access to the vaccine. It doesn't address access to other services that pharmacies provide. So we need to prevent pharmacies from closing. And to do that, we need better policies, including CMS, for example, Medicaid and Medicare, ensuring that all pharmacies that are in these areas that are pharmacy deserts are protected at a minimum from closing. Like a critical access hospital, disproportionate share hospitals, they get reimbursed more to ensure that they stay open. It was kind of a way that the government tried to address rural hospital closures. And even during the Nixon era, they had a certificate of need that required hospitals before they opened in a neighborhood to ensure that they were actually needed. That was repealed, but there's still some 20 states that have that in place. And I think those are policies that we need to institute to protect pharmacies from closing, to incentivize pharmacies to open up in areas that need them, like pharmacy deserts, and to address kind of the disparities we see in medication access, because we did also find that when a pharmacy closes, people stop taking their drugs. I mean, simple as that. Kind of this rigorous longitudinal study that we've conducted, and we found that it not only declined, patients not only discontinue taking their cardiovascular drugs we focused on, that they include anticoagulants, which if you don't take, it's not like preventative treatment, right? They're critical. You need to take them on time all the time, or it could really affect morbidity and mortality. So it's important to address these disruptions in closures and pharmacy deserts through policy, whether it's through financial incentives or through other kind of regulations that ensure equitable distribution of community pharmacies across the country, but especially in neighborhoods that we know now are pharmacy deserts.
Well, thank you for that really robust answer. I think it's no. As I was hearing you present, I reflected back on some things that were happening here in Massachusetts, and again, you draw a clear distinction between access to a vaccine versus access to a medication. But even here in Boston, which as much as Boston likes to say it's a big city, it's not. It's a relatively small city. But when you look at where they put the vaccine clinics, when we were first popping those up, they said, "Oh, we're going to do the football stadium and the Heinz Convention Center." And those were areas that were not where Black and brown people lived. And in order for us to have access to those vaccines, we had to travel to those places. And yes, we were trying to make those medication or the vaccine as open to all as possible. But in reality, we weren't thinking about those who were going to struggle the most to get access to that. And when you sort of brought to the point about critical access and hospital closures, we often don't think about pharmacies in the same light, because we have that mentality that pharmacies just provide one particular service, not recognizing the downstream effects for that. So it was really a very thoughtful answer to that question. And as I'm hearing you present, I think we need to bring these people together, whether it be the drug developers, the retail pharmacies, and insurers together to the table to make this more equitable. But how do we do that? How do we get these people to work together to think about the patients that are excluded from these discussions oftentimes?
Yeah, so I mean, that's a question I think a lot of people want answers to, right? And because I think it has to do a lot with what's a mild word? I mean, the lack of accountability and transparency of our health system. I'm kind of hesitant to say corruption because I don't think it really advances us, but I think it's important to, when it comes to pharmacy closings, like you brought up Boston, those 3 chains that closed. Okay. A year ago, CVS announced they're closing 200 plus stores. Maybe 2 years ago, Walgreens announced. I responded and they responded saying their business decisions were being careful not to close in underserved neighborhoods that are pharmacy deserts, et cetera. But our data tells us otherwise. So those 3 pharmacies are probably in publicly insured neighborhoods, right? Disproportionately low income, likely for different reasons, disproportionately minority, Black or Latinx or immigrant populations. So how do we get together? Well, one, I think retailers have to we have to increase their accountability. And yes, they're part of the retail sector, they're businesses. And I think that's part of the challenge is how to, and this is kind of, I tried to 2-3 years ago when I was in Chicago, work with retailers, the city of Chicago, Illinois Medicaid to kind of address this problem, at least at the state level. And some of the barriers were identified was one, how do you regulate a business that is not considered a public service entity, really by law, aside from removing, the free market rights of, corporations. It's hard to do that unless there's kind of regulations. And so, okay, in terms of regulations, who could we regulate? What's the root cause of these problems? And if we look at the root cause is how plans are contracted, PBMs, pharmacy benefit managers. They're really who are orchestrating kind of these arrangements between, I'm just using Medicaid and Medicare as an example, and how much pharmacies are being paid for. So even when you have a pharmacy located in a neighborhood, even if it's a chain, right, it doesn't necessarily get reimbursed fairly, depending on what kind of the relationship that chain has with the insurer. And I'll give you an example of what happened in Illinois, just to kind of illustrate how this dynamic is very challenging and we really need to regulate insurers. I also think retail pharmacy organizations, before you open 2 pharmacies, in a high income neighborhood that already has like 10 pharmacies per square mile, open one in a neighborhood that's a pharmacy desert first. That could be a law. I mean, that was a law that I proposed for the city of Chicago, and they kind of laughed it off. And then COVID came along and they were like, oh my God, we should have done something when we had the chance, because now it's like people don't even have access to their medications. But anyway, so in Illinois in late 2020, Illinois Medicaid basically dropped Walgreens, the largest chain pharmacy serving communities of color in the city of Chicago, and actually throughout Illinois. And in different states, it's either CVS or Walgreens, but in the city of Chicago, it accounts for 50% of chain pharmacies in the city, right? And the chain pharmacy that's most likely to serve communities of color. But Illinois Medicaid made the decision to just kind of take it off the network. So basically, if you had Medicaid and this specific plan of Medicaid, which is the majority of Medicaid beneficiaries in the city, you were not able to go to a Walgreens. And that, I mean, think about that. It's not even independent. It's a Walgreens. It's a chain. It's a powerful chain that was just knocked off. And the defense there was we met adequacy standards that the state told us we had to meet in order for our contract to, and this is CVS, right? So CVS was now the preferred in-network, even though before it was both CVS and Walgreens, but CVS negotiated its way where they excluded their competitor Walgreens. And now everyone had to go to CVS. But CVS was not accessible. It's just one chain, but it's not accessible in neighborhoods that are pharmacy deserts, right? That even in the nearest pharmacies were often Walgreens, if not independents. And forget independents, they're totally out of network in the past, right? So they kind of already succumbed to the difficulty to sustain. But Walgreens wasn't. It was in network. And many of those pharmacies that were closed in the last 2 years that were Walgreens closed, right? So going back to Boston, I don't know if there were Walgreens or CVS's that closed, but they're closing because there was a system signed off by state governments oftentimes, right? Based on standards that are antiquated, unreliable, and actually discriminatory. And those adequacy standards are so adequacy standards, for those who don't know, they are in most plans for even primary care providers, some specialties where a plan has to make sure that a beneficiary has access within a certain mile radius or minutes driving to a healthcare provider. Unfortunately, most plans don't require pharmacy adequacy standards, particularly private insurance, but Medicaid and Medicare do. But those standards are 15 miles. Okay, so if you know anything about Chicago, running north-south, it's just 24 miles, right? About, plus or minus. It's very easy to meet that standard. I mean, it's 100% compliance. So that standard that CVS said it met, or Aetna CVS, right, was easy to meet. Why? because, I mean, just geographically. And the state then wanted us to kind of prove that there was a problem, and we did, but it wasn't enough because of this reliance on, like, they didn't really do anything wrong per regulations. They met a standard and we signed off on it. And then it's in a standstill, right? So what should have happened is that they should have made it open network, right? Because so some of those Walgreens closed, by the way. I think I missed that. So those Walgreens in Chicago that were excluded, they closed. And whether they closed because it was pre-planned or as a function of being excluded, it's hard to tell without, empirical evidence. But if we learn anything from history and prior kind of evidence, it's likely a combination of both. But in this case, probably because they were excluded from the network and therefore had fewer patients coming into their stores to fill their medications, right? And it's not usually because of, theft and burglaries and all that stuff that goes around. That's not why pharmacies honestly close. I mean, there are rare cases where that may be a reason, but most of the time it's not that. So I want to make sure that's something that's not part of this. We want to dispel that myth that it's unsafe for pharmacies to be in certain neighborhoods and they don't want to be there. No, that's not true, right? There's a lot of independent pharmacies that open in communities of color, even communities that are considered high crime by whoever's categorizing them. But they stay open and want to stay open, but oftentimes are forced to close because they can't, stay open. They don't have profit, right? Like their businesses. The government isn't giving them money. It's paying them like less than what they're paying for their medications. Medicaid and Medicare reimbursement rates because the PBMs are lower. So, the solutions, so I'll go back to what the government, at least from the federal and state policy level, should be doing. And one, I think it needs to include pharmacies in open networks. We can't restrict access. We already have lower access to pharmacies, right? We have pharmacy deserts. So at the minimum, for Medicaid beneficiaries or Medicare living in neighborhoods that we know have low access to pharmacies and other services, there should be open networks. They should be able to choose where they go and not mail order, right? They should be able to go to a brick and mortar store. Mail order is not a solution to pharmacy deserts. That's one. And that way that could prevent pharmacies from closing. And also it kind of gives people a choice, the freedom of choice to go where they want, what's more convenient for them, not force certain people living in certain neighborhoods to travel 2-3 miles or take 2-3 buses, and others that could just kind of stroll like, a few minutes outside their home to fill their medications. That's unfair, that's unjust, and that's structural racism. So at the minimum, networks should be opened. And I think, and doing that could prevent closures. I also think we should model at least the advantages of having these designations of critical access hospitals, medically underserved areas, and apply them to neighborhoods in terms of pharmacy access to incentivize pharmacies to open in those areas. So they get paid more for their prescriptions if they open up in these neighborhoods and that are mostly Medicaid or Medicare, that are pharmacy deserts. Medicaid and Medicare would pay them more per prescription than other pharmacies serving, less publicly insured low-income populations. And I think, there's other solutions at the policy level, but I think third is kind of building off programs that we already have, like 340B, and ensuring that they're used in a way, like those millions of dollars of funding go to 340B kind of covered entities and their contract pharmacies. But there's no accountability, again, of where that money's going and whether it's actually benefiting the community and the patients that are the target kind of population for that program. And I think if it's used, for example, to promote home delivery, right? I know in Massachusetts, it's one of the few states during COVID, for example, that just, I think for 6 months, paid pharmacies to home deliver to Medicaid participants, their prescriptions. It's North Carolina and I think maybe New Mexico were the other 2 states that did it just for the first phase of COVID. But that needs to be kind of standard, right? Like if an older patient relies on their grandson to pick up her medicine or his medicine, because she lives in a pharmacy desert, she would benefit from that service, right? But she could choose that service. She shouldn't be forced to use it, but it should be an option for her or him. So I think, financing home delivery either through 340B funds or otherwise is an option to ensure access is, addressed, not just during COVID, but just all, these problems we saw during COVID were just highlighted, but they existed far before COVID even started.
I think COVID was one of those opportunities for us to see all the things that we had been sweeping under the rug for so many years, only to have the rug removed and everyone can see what we were trying to hide. I want to turn quickly to just two other questions, just looking at the time. And I want to go first to you, Jam. I think you alluded to this briefly, and I would love to maybe tease this out. This is probably a discussion for a different day. One of the things that I'm passionate about is workforce diversity. Can you talk just a little bit about what does that student body in pharmacy schools look like? What does the diversity within the profession look like? And just wondering, maybe 1 or 2 minutes, does that have an impact on sort of these issues that we're talking about here with Pharmaco-Equity and pharmacy deserts?
Alden, thank you so much for this question. I love it, but because it's something that I'm really passionate about, but I want to be very vocal when I say the diversity is not there. And we often have that conversation of, oh, we're increasing and we see exponential increases here. Well, here's the issue. So not only do we have inequitable representation, but then we have the HBCUs that have more stringent, that have to meet these stringent requirements, have less help. But then when they close down, we lose like 30% of the diverse individuals that we would have had in the profession. So to put this into perspective, Hampton recently lost accreditation as a school of pharmacy. So with the number of Black students that Hampton produces, it would take 7 predominantly white institutions to graduate the same number of Black graduates that Hampton would graduate in 1 year from their program. It would take 7 schools to match that number. So let that be just the driving force for what it is that the landscape in pharmacy looks like in terms of diversity. So for Black pharmacists specifically, a little less than 7% of current practicing pharmacists are Black or identify as Black. And then, the other minorities are definitely less represented. But I think what my major issue is that we don't do enough in terms of data de-aggregation. So then you end up in this place to then when they display Asian individuals, it's like, it may be one predominant group, but it's like, oh, it's an overrepresentation of individuals within this racial group. Well, no, but there's no data de-aggregation. So now we can't even figure out where the disparities lie. So we're not even on the track to where we can uncover where these disparities really are. But I think that it's a really good point that you bring up in terms of health equity, because the lack of diversity, it really takes away from that racial concordance that is just. So I think that Dima did I really love how she drove home just that it is just it's a human right that people deserve. People deserve to be able to receive care from someone that can identify intimately with their lived experience. People deserve that. We deserve to have at least a percentage of practicing clinicians that is representative of the United States demographics. We deserve that. So I think that we have a lot of work to do, but I think that we also need to prioritize the historically Black institutions that are more likely to take minoritized trainees and minoritized students. We have to prioritize ensuring that these places remain intact and remain in structure, that we provide them with the resources necessary for accreditation and so on and so forth, because they are just so integral to us being able to have racial concordance. Pharmacy, medicine alike, in my opinion.
Thank you. And thank you for speaking directly to the issues that our HBCUs are facing. What you're mentioning around pharmacy institutions is the same that we hear about medical schools, dental schools, et cetera. So I think this an unfortunate issue that our HBCUs are having to deal with. Utibe, I want to turn to you for just our last question. You brought in an acronym for us to learn with the ABCs of Pharmaco-Equity. But another thing we have a lot in medicine is algorithms. And, is there a role for using algorithms to better address pharmaco-equity issues, especially from a prescriber perspective?
Yeah, that's a great question, Alden. And again, I know we're at the hour here. The tricky point about algorithms, I think, is that because of the data that we have that in and of themselves are disparate because of who has access to a clinician, who has access to our hospitals, et cetera, it can sometimes lead to further bias. So we've seen that conversation with algorithms for some of the various machines that we use in the hospital. The pulse oximeter is something that came up recently. Algorithms for how we determine, excuse me, different patients go for certain types of cancer screening because of their skin color, et cetera. So I think we just have to be really cautious when we use algorithms. For me, along with the ABCs, I'm all about making the right choice, the easy choice. And so wherever we can implement a system in place, whether it's a best practice alert in our electronic medical records or something to that effect, to make it so, for example, in the case of atrial fibrillation, you don't even have a chance to prescribe warfarin for a patient that is eligible for a newer blood thinner medication. You just automatically get that alert to prescribe the right therapy. I think there's plenty of data to show that systems like that, nudges, I think they're often being referred to as, do help us make more equitable choices. And so just two words, points is to be cautious around algorithms to ensure that they don't have biases baked into them, and really thinking about nudges and kind of best practice alerts as a way to address the equity issue.
Awesome. And I just want to close by saying thank you to our panelists for bringing their thoughts, their expertise, their experience, and their knowledge to this discussion. It really opened my eyes personally to some of the issues that my patients may be facing as I go and care for them in the emergency department. And as you know, I refer them to either my colleagues on the internal medicine side of things or send them out with a prescription for a medication and to interact with a pharmacist. So this is just really an important conversation. I'm glad we had this discussion from an interprofessional perspective. And I'm really glad that we had this discussion thinking about this from the local level all the way to the policy level on the national level. And I think it's really important for us to have these discussions where we include all of that context. I think from the way that Dr. Cato was presenting, we probably could just have a whole hour-long discussion around policy interventions, which are needed to truly address these pharmaco-equity and pharmacy desert issues. So to the audience, thank you all for joining us. To Dr. Reed, thank you for ushering us along with our Equity and Social Justice lecture series. To Lynn, who is behind the scenes for us organizing our program, and to my amazing panelists, Tashinda, Dima, and Utibe, thank you for joining us. This webinar will be posted online in about a week with closed caption for those who use visual aids for education, and look forward to seeing you all at future ESG events, which we have coming up planned in the next few months. Everyone have a good afternoon and enjoy the rest of your day. Take care.
Thank you.